All right, so I have the pleasure to moderate and start the esophageal section. So I know that we're limited on time, so I'm going to be efficient today. So I'm going to introduce the first speaker, which is Dr. Jiang. Dr. Jiang is a clinical assistant professor with a focus in esophageal motility disease, has a master's in epi and clinical research. We're excited to bring him back from Southern California as he recently just started. So he's going to give a talk today about the new directions in reflux treatment. And with that, Dr. Jiang, you can go ahead and get started.
All right, thanks everybody. My name's Jiang, and I will be giving a brief talk today on sort of the new developments in GERD management. So a brief outline. So I'm going to talk a little bit about the diagnosis of GERD, keep that brief, and then really focus on treatment with a breakdown in lifestyle management, medical therapies, surgical and endoscopic options, and then finish off with a discussion on sort of the new therapy coming for GERD. So this is the diagnostic algorithm provided by the FACG guidelines, the recent ones published last year on GERD. Really kind of focuses on something we kind of have been doing, which is really starting with a PPI trial for those with classic heartburn symptoms without red flag signs. And in general, I think historically it hasn't been super sensitive or specific, about 78% sensitive, 54% specific for PPI trials, but a lot of the societies recommend it because it's very efficient and practical. So I think the first thing we start with is an 8-week, once daily PPI, and then if there is relief, this is most likely GERD, and would recommend a trial of discontinuing and seeing how symptoms do. And for those who have initial incomplete relief or who have recurrent symptoms after discontinuation of PPI, the next step really is to do an EGD and ideally 2 weeks off of PPI. The EGD findings, if they're consistent with GERD, so severe erosive esophagitis, so LA grades C and D, some would also say B if there are classic GERD symptoms as well. Barrett's esophagus, then you have a confirmed diagnosis of GERD. And for those who have a normal EGD or very nonspecific mild esophagitis, I recommend doing reflux testing and with pH monitoring off of therapy. And if this is abnormal, then again, it would confirm GERD. If it was normal, then you would consider other causes for the symptoms. And that's an area we won't get to in the talk today. So a little bit about some updates on the diagnostic tools that we have. So with pH monitoring, there's catheter-based 24-hour testing, and there's wireless pH testing. Now there's 96-hour capability, and that gives us a little bit more data, a little added sensitivity to the test, and allows you, if you want, in the last 48 hours to test some sort of intervention, PPI, some sort of dietary modification if you want. The Lyon consensus published a couple years ago, several years ago, I guess now, basically with the pH monitoring, an acid exposure time of over 6% is diagnostic for pathologic GERD. And then I wanted to mention a little bit more about the newer metrics that really are based off of pH impedance that can be useful and helpful in the diagnosis of GERD, maybe especially for those people kind of in the intermediate range and you're not totally sure on the diagnosis. So there's the post-reflux swallow-induced peristaltic wave, or PSPW, and that's representative of esophageal reflux clearance. There's baseline impedance, which is representative of mucosal integrity, esophageal mucosal integrity, and this is done either through a calculation of pH impedance, so the mean nocturnal baseline impedance, or now there's direct endoscopic measurements that you can do during endoscopy with a balloon catheter, and that's the MyView system. And so the graph on the right here, I want to highlight, this was a cohort study that was published just last year that was looking at some of these newer metrics in PPI-dependent heartburn patients. And you can see this is the area under the ROC curve, and you can, I don't know why this is not shining here. Here we go. You can see with the PSPW and the MNBI, you can see that they're actually relatively good diagnostic discriminators for GERD and controls. Okay, so I'm going to shift over and talk a little bit more about the treatment now. and focus the initial talk on lifestyle modification. I think this is an area that a lot of patients that we see are interested in, but the data is not so great. And so a lot of our common recommendations have limited evidence, and there's a lot of times variable results that come with that. Certain practices and foods can decrease LES pressures, but studies really aren't clear on the benefits of avoidance of those things. Conversely, even if foods don't have an impact on LES pressure, they can still cause symptoms to patients that seem like GERD at least. And so with lifestyle modifications, really this is a good area to have really individualized recommendations for patients and just let them know kind of the data is really mixed on a lot of things. And going to the right here, I think the recommendations that have the most data and sort of the best data are really weight loss in overweight or obese individuals, and avoiding sleeping on the right side. Avoiding eating before bed 2 to 3 hours at least. This avoiding of trigger foods, I think, at least I tell patients, are very specific. So some people get really bothered by citrus and coffee and not others. And the data on those things are pretty mixed. So if someone has no issues with it, I don't tell them to avoid it. And smoking cessation, I think, is a very recommendable thing. The data, again, is pretty mixed. Okay, so moving towards medical management. So PPI is still the mainstay of treatment, especially for healing of erosive esophagitis, as well as symptomatic relief of heartburn and regurgitation. It binds to active secreting proton pumps, and so thus it's best given 30 to 60 minutes before meals. Maintenance PPI is indicated for those with severe erosive esophagitis, so LA grade C and D, and those with Barrett's esophagus. For those who have refractory GERD symptoms, first thing we want to do is try to optimize the PPI. So making sure they're taking it properly 30 to 60 minutes before meals or 30 to 60 minutes before dinner if predominant nighttime symptoms. Can also add to twice a day PPI, and a switch to a different PPI is reasonable at least once. Additional medications, so H2 blockers are effective additions either at night for symptomatic management or sort of on an as-needed basis. Long-term use, sort of daily long-term use, is limited by tachyphylaxis. And also alginates are something that I recommend a lot, I guess. Alginates with antacids, so Gaviscon double action, dual action. They've been shown to reduce GERD symptoms in randomized control trials against placebo. And essentially the idea is that this alginate, which is a seaweed extract, when it gets in contact with gastric acid, it makes this essentially gel barrier to try and prevent reflux back into the esophagus. Okay, so a little bit about PPI safety, but not too much because I know Dr. Shah is giving this talk after. So the most common side effects are headache and kind of a slew of nonspecific GI symptoms. They occur infrequently and go away once PPI is stopped. There have been growing concerns of PPI safety. Most studies are observational. So this table on the right here, this is from a randomized control trial that was published in 2019. It was a study of 17,500 patients who were on rivaroxaban plus or minus aspirin, and they were randomized to either get pantoprazole or placebo. And basically the median follow-up time was 3 years. I think the longest follow-up time was around 5 years. And basically the result here was that there was a slight increased risk in enteric infections. There was also a slight increase in C. diff, but because the number of patients were so small, the C. diff increase was not statistically significant. I think that mainly, I think the point here is that, there is this one large randomized control trial, but there is still a lot of data that's out there, and they might not be the best quality, but I think they should keep in the back of our minds, really reemphasize the importance of why we're prescribing PPIs and who really should continue on these medications. Okay, so moving to surgical and endoscopic treatments then. So really their surgical options are really for people who have long-term treatment of objectively diagnosed GERD, especially those with severe erosive esophagitis, or large hernias, or persistent bothersome symptoms. Laparoscopic fundoplication is still really kind of the gold standard procedure. And in a large study, basically recurrence of reflux happened in roughly 18% with a median follow-up time of 5 years. So magnetic sphincter augmentation or LINX seems to have similar rates of GERD symptom control, post-op PPI use, major complications. There's not as much data on MSA as there is for fundoplication, but the data right now seems to point towards that they're pretty similar. And it appears to be pretty effective for those with persistent regurgitation symptoms despite PPI. For your patients who are overweight, obese, Roux-en-Y gastric bypass can be a consideration, really, but they need to be counseled pretty intensely about sort of the side effects that come with long-term bariatric surgery and to have a discussion with the appropriate surgeon. For endoscopic options, currently there's really two. There's radiofrequency anti-reflux treatment, or STRETA, and there's the transoral incisionless fundoplication, or TIF. So it's not typically done for those patients with larger hiatal hernias and not for patients with severe esophagitis. There's been some conflicting evidence on STRETA on the efficacy, and there's really limited data, long-term data for TIF, but these are options for patients who really don't want to undergo surgery and they'd rather have endoscopy. So I want to highlight this study for two main reasons. So this was a study published in the New England Journal in 2019, and it was a study evaluating basically medical therapy versus surgery for treatment of refractory heartburn. And so the first thing on the right here, this is the result that was published. So in 78 patients who had reflux related PPI refractory heartburn, it seemed like the anti-reflux surgery improved quality of life, improved GERD symptoms based on a GERD quality of life survey at 1 year follow-up. And this was more efficacious than medical treatment, either with PPI plus baclofen or PPI plus placebo. I almost think that one of the more important things that gets pointed out by these results, as you can see on the left here, that how many patients were referred for refractory heartburn, so over 380 patients, and how many patients actually were deemed to have true PPI refractory heartburn. And this was based on either a positive pH impedance test on PPI, so you had an elevated acid exposure time, or you had positive symptom correlation. So I think it really just highlights the fact that there was only about 21% of this cohort who, when they were referred for PPI refractory heartburn, truly actually had reflux-related PPI refractory heartburn, and most were deemed to have symptoms for other reasons. Okay, and so I just want to finish quickly talking about sort of the new therapy on the block. So these are the potassium competitive acid blockers, or PCABs, and they're a new class of agents that appear to bind both active and inactive proton pumps. They're acid stable, so it allows for a rapid onset of action. They're more potent in suppression of gastric acid than PPIs. A study of the first PCAB, so vonoprazan, it was mostly conducted in Asia, and it's been used there. It was shown there to be non-inferior and slightly more efficacious to PPI. The PPI they used was lansoprazole in healing of erosive esophagitis. And I'm just going to go on the next slide, which is the study that was conducted here that was published this year. So this was looking at once daily vonoprazan versus once daily lansoprazole. And this was looking at healing. The primary endpoint was healing at 8 weeks. And then they also, for those who had healing of their erosive esophagitis, randomize them into vonoprazan at 20 milligrams or 10 milligrams and lansoprazole for sort of maintenance of healing. And you can see, so the result here is that at 8 weeks, there was a higher rate of healing with the PCAB. And this was especially so in those with severe erosive esophagitis, so LA class C and D. And for maintenance, the 20 milligram vonoprazan dose seemed to have higher maintenance healing than the 15 milligrams of lansoprazole. These were higher healing rates than the studies done in Asia. And I'll just say that for PCABs, they were approved for use last year for H. pylori, but there's kind of been some delays in getting the medicines on the market. There's some impurity issues with their medication. So the FDA actually hasn't looked at their proposal for using PCABs for esophagitis. It's right now only approved for H. pylori. Okay, so just finishing with a few points. So first, for just, you see a patient with GERD, start with PPI trials for patients with classic heartburn without alarm symptoms. Consider endoscopy and pH monitoring for those with recurrent symptoms after PPI trial or those with incomplete initial relief on PPI. Newer diagnostic metrics are available to help have a clearer diagnosis. I think it's important to remember that most times PPI refractory GERD symptoms are really not truly related to reflux, and further evaluation really should be done prior to more invasive therapy. There are many options for individual treatments for patients, but those with severe erosive disease will likely need long-term PPI or surgery. And a newer class of medication, the PCABs, are on the horizon. They may be especially beneficial for those with severe erosive esophagitis or true PPI refractory reflux. All right, thank you.
So for the next speaker, I'm going to introduce Dr. Atul Shah, who's going to talk about how he counsels patients when prescribing PPI. Dr. Atul Shah is a clinical associate professor here in our GI division, managing both GI and liver diseases, and has a special passion for global health and is actually the director of Health Volunteers Overseas in Bangalore, India. And with that, I have a pleasure to introduce Dr. Shah to the podium.
Good morning. First, I would like to thank the panel for asking me to talk about this very interesting topic, and also thanks everyone for attending in person as well as virtually. So, what do I tell my patient, about PPI? And it's I thought that I knew my PPI very well, but we'll see. So this PPI, omeprazole, was approved in 1989, and I'm so thankful. I was the first-year fellow. That changed my life then and changed my life forever with all the GI bleeders. Subsequently, we got an approval of lansoprazole and other PPI. This was available over the counter in 2003. About $10 billion healthcare cost in US and about $25 billion globally. The safety concern about the PPI, they started being addressed somewhere in 2006. So before we go to the safety concern, I think like any other medications, it's very important to first look at the indications. Because we all have patients who are on PPI. For whatever reason, patients don't know, and we can figure it out why they are on PPI. And they're on PPI forever. So I think first we should go back to the drawing board at some point and say, okay, is the patient on the medication for the right reason and for the right duration and for the right doses? So we'll revise this indication. You all know it very well. Just for us to revise, these are the indications for which FDA has approved PPI, GERD, erosive esophagitis, ulcers, NSAID-induced ulcers, prophylaxis, H. pylori combination treatment, and some hypersecretory states. I'd like to add one more point. This is a class 1 recommendation from European Society of Cardiology as prescription for PPI in a post-MI patient and a dual antiplatelet. It showed clear benefit in reducing clinical bleeding outcomes, and this is something I always keep in mind along with the other indications. So regarding the efficacy, safety, all the concern raised, I've broken down into three different parts. So one is the strong evidence but limited clinical significance. And we'll talk about this in more detail, but just to go over it, alteration in the gut microbiome, enteric infection increase, drug-to-drug interaction, microscopic colitis, and hypomagnesemia. And we all have seen this on endoscopy. 10% of the people on PPI have fundoplication polyps, have no clinical significance. These are the conditions with weak evidence, dementia, MI, stroke, bone fracture, kidney disease, C. diff, pneumonia, and death. And I have a reference for each individual indications and about the possible adverse events reported. So if somebody is interested, email me and I can send the details of that. These are with no significance known, hypergastrinemia and carcinogenesis with elevated gastrin. So the question is, why so much scare? So the reasons for the scare is we continue to be flooded in both medical and lay media literature with a retrospective, database-driven, observation population studies and meta-analysis on the same studies. So these studies are flawed by multiple inherent biases. You cannot ascribe cause and effect. A laundry of serious adverse events associated with PPI, and only few have been examined in randomized trial, which is the most scientific way to do anything. Of those that have been examined, causality has been largely debunked. So in the interest of time, we won't go of each and every associated PPI event described, but I'll go over a few studies. And what happens because of this scare? The issue is because of the scare, the patient take themselves off PPI or the prescriber stop the PPI. And this is the nice article that I came across where 70% of the internists who completed online survey voiced concern regarding PPI side effects and changed their prescribing habits, particularly in a high-risk GI update prevention scenario. 79% inappropriately recommended discontinuation. So if you look at some of the studies, this is one of the studies done in VA, all-cause mortality and cause-specific mortality, published in British Medical Journal in 2019. A lot of issues with this study. Majority of the patients were elderly white male, selection bias. This used the ICD-10 coding for specific cause of death. No information was given regarding their weight, diet, smoking, compliance. So very little can be learned due to this selection bias and other issues. The second study is the National Ambulatory Medical Care Survey 10-year data, interpreting reported risk associated with PPI. No association was found between PPI use and dementia, pneumonia, intestinal infection. Creatinine was slightly, higher change, which was same with any other medication. Again, this was published in 2020. This is the one Dr. Jiang mentioned. And, this is the one that I really like this study because this is the one landmark prospective randomized placebo-controlled study. 18,000 participants. 8,700 participants got pantoprazole. 8,800 got placebo. They were on rivaroxaban or aspirin. And they were studied for 3 years. The data was collected every 6 months for development of potential PPI-associated adverse events. And interestingly, this is what they found. There was no significant difference between pantoprazole and placebo in the development of dementia, cardiovascular disease, fracture, kidney disease, pneumonia, diabetes, gastric atrophy, cancer, and all-cause mortality. The enteric infection, as Dr. Jiang mentioned, is a little bit higher, 1.4% versus 1. And there were 13 events of C. diff, but clinically this was not significant. So what do we learn? So PPI are safe up to median of 3 years, maybe more than 5 years. It should be prescribed for valid indication, and this is the most important point. I think this is the number one prescribed medicine in our country. Many of the time, this medicine is not prescribed by gastroenterologists. And there is one study just recently came out, not from here. It showed that the PPI was prescribed primarily not by GI. So we need to revisit the patient's medications and see why the patient is on. It can be used long-term with periodic assessment and try to aim to the lowest effective dose. I'm not sure what happened. Oh, yeah, okay. I'm still in my time zone, right? So the PPI are also safe during pregnancy. There's always a concern. Can we give PPI, yes or no? No significant association was found between PPI and following: abortion, stillbirth, neonatal death, preterm, low birth weight. Risk of proton pump inhibitors during pregnancy, this is the publication in 2020. During early pregnancy, the risk of congenital malformation, none. So PPI can be safely used during pregnancy. This is the new kid that everyone is talking about, gut microbiome. Everything is connected to the gut microbiome. So as the gastric acid protects the GI tract against the colonization, we can assume that PPI will reduce the gut microbiome, and it may play a role in enteric infection, hepatic encephalopathy, and gastric carcinogenesis. Let's dive in a little bit more deeper so that we know exactly what the study shows. So PPI predisposed to enteric infection, published by Dr. DuPont, reported in the journal, and it said because acid-sensitive organisms are suppressed, and there is a more chance of enteric infection. The studies have limitations because the actual PPI doses were not available. The determination of the gastroenteritis was only based on the drug dispensive data. I don't know whether we can go by that. Association with the PPI and CDEF is controversial. The data are not compelling, as all studies are observational, retrospective, non-randomized, and suffer from significant heterogeneity. Hepatic encephalopathy. The gut bacteria plays a role in hepatic encephalopathy. It may increase the hepatic encephalopathy risk. This was studied and published in World Journal of Gastroenterology in 2019. Several limitations. The results that show several limitations, but definitely we need to be cautious in prescribing PPI and cirrhotic, because in this particular study, they found that 42% patients received PPI without a definite acid-related indication. So again, we have to look at the patient and see why the patient is on PPI before we make further recommendations. By raising the gastric pH, it does modulate the gut microbiome and could adversely affect the bioavailability of certain medication. And this is important because it does decrease the absorption of thyroid kinase inhibitor, as reported. It may reduce the clinical benefit of immune checkpoint inhibitors and oral chemotherapy, even though the effect is small and clinical prevalence is uncertain. But I think we should use PPI very judiciously, particularly in these patients who are very sick. There is a reported risk of sudden death, cardiac arrest in patients using omeprazole and citalopram. Again, there are a lot of limitations of this, but definitely it would be a good idea to give BPI before breakfast and SSRI after dinner. Does it affect the nutrition, micronutrient deficiency? FDA has issued some warning about long-term use of PPI causing hypomagnesemia. Even though this is rare occurrence, then no prospective control studies exist to support the causation, but it was found 3.164 higher in patients who are HIV positive on PPI than non-HIV patients. The bigger issue nobody is talking about, we all talk about this safety concern, but many of the patients are taken off the PPI just suddenly. And these patients do get rebound hypergastrinemia. So this is the problem, and the PPI should be discontinued slowly. And the algorithm recommended is to do it every other day for 2 weeks, every 4 days for additional 2 weeks, and then stop to prevent rebound hypergastриnemia, as reported in this article in 2020. So, take-home points, make sure the PPI is used for the appropriate indication. Using for long-term proposes no significant risk. We have to educate the patient and prescriber about not stopping the medication just because of the fears and concern. Deprescribing PPI should be done as discussed and not abruptly. And check creatinine every year, CBC every 2 years, and B12 every 3 years, and magnesium level on an HIV patient yearly. Give PPI and SSRI 12 hours apart to minimize the potential but rare cardiovascular issues. Again, be careful using the PPI in patients on tyrosine kinase inhibitor, oral chemotherapy, immune checkpoint inhibitors, and reevaluate the long-term need for PPI, especially for more than 3 years, as the safety duration has been studied in randomized controlled trials up to 3 years. Thank you very much.
Our next speaker is going to be Dr. Patricia Garcia, who's going to talk about updates in EOE management. So Dr. Garcia is a clinical associate professor in our division, also director of our GI motility lab, and more recently, which is super cool, she became the associate chief medical information officer of ambulatory care. Dr. Garcia, you have the podium.
All right. Well, thank you, Afrin, and to everybody for giving me this opportunity to talk about eosinophilic esophagitis updates and treatment. So I'd like to start by briefly reviewing how we think about and diagnose EOE, which interplays with how we treat it. So EOE is a chronic, progressive, antigen-mediated inflammatory disorder of the esophagus that affects both adults and children. It's a clinico-pathologic diagnosis that requires a constellation of endoscopic, histologic, and clinical symptoms depicted here. The natural history of EOE is that over time, typically years of time, the eosinophil predominant inflammation will lead to esophageal remodeling and fibrosis, which ultimately can cause luminal narrowing. In children, the inflammatory phenotype is more common, which is why kids usually present with feeding difficulties, vomiting, and abdominal discomfort. Over time, as fibrostenotic progression occurs, the symptoms we see in adults, like dysphagia and food infections, tend to occur more dominantly. So as we move on to treatment, it's worth thinking about this pathophysiology, as different treatment strategies may be more appropriate based on where someone is in this progression from inflammation to fibrosis. So let's start with diet. There are 3 basic approaches: an elemental diet, elimination diets, and allergy test-based diets. The main figure on the left summarizes the histologic remission rates achieved with each of these different dietary strategies, and the insert shows the 6 most common EOE food triggers ranked from least allergenic to most, which are fish, shellfish, nuts, tree nuts, soy, eggs, wheat, and dairy. A few things to notice here. The overall effectiveness of the elemental diet to achieve histologic remission of EOE is 90%, which makes it not only the most effective dietary approach, but by far the most effective approach. Unfortunately, poor palatability, high cost without universal insurance coverage, and negative impact on social activities and quality of life are major barriers, especially in adults. The least effective diets on the bottom are single food elimination with dairy and allergy test-based eliminations. While newer approaches to allergy testing, like direct esophageal prick testing or EPT, as well as food-specific serum IgG4 testing are being researched and are promising, the current approaches, like serum-specific IgE or patch testing, unfortunately lack the sensitivity and specificity to drive therapy in most patients. So that leaves 6, 4, and 2 food elimination diets as options that are more practical than an elemental diet, but more effective than dairy avoidance or allergy-guided options. So when it comes to these elimination diets, the top-down approach on the right, where all 6 foods are eliminated simultaneously, has historically been the most common. If after eliminating all 6 foods, a repeat endoscopy shows histologic remission, a long journey of single food reintroductions followed by up to 7 endoscopies that can take almost a year is initiated. And because this process is so prolonged, expensive, time-consuming, and difficult to adhere to, it's really not a common approach for most patients, or at least for most adults. On the left is the newer step-up empiric elimination diet, or the 2-4-6 diet, along with the approximate histologic response rates in red. So patients first eliminate dairy and gluten and undergo an endoscopy. If they're not in histologic remission, they'll additionally eliminate eggs and soy and undergo another endoscopy. And if they're still not in remission, they will additionally eliminate nuts and seafood. As you can see, this approach significantly decreases the number of endoscopies and the time required to identify likely dietary triggers. So bottom line for dietary treatment is that for patients who are highly motivated to undergo dietary therapy, these options can be quite effective and sustainable. That said, the process can be time-consuming and expensive, as well as being socially limiting and difficult to maintain. So it's really important to discuss these issues up front. Final slide on diet, which I'm not going to go through in detail, is from a great article that was published just last month online ahead of print in CGH from Jiang and colleagues, which provides a practical guide for implementing and monitoring dietary therapy. It's got great resources on diet elimination strategies, including what I'm showing here, which is a list of websites and apps and books that your patients can use as they embark on their diet journeys. So now I'm going to move on to medical therapy, and I'd like to start by quickly reviewing the pathophysiology of EOE. So what you can see here is that food antigens interact with the esophageal epithelium to elicit a T-cell mediated response, which then leads to the activation of cytokines like TGF-beta, IL-4, IL-5, and IL-13. These cytokines then lead to activation of mast cells and eosinophils, which cause inflammation, loss of epithelial barrier function, and tissue fibrosis. The medical therapies we're going to talk about next target one or more of these pathways. So let's start by talking about PPIs. So while the use of PPIs is technically off-label, many studies over the last 10 to 15 years have looked at the efficacy of PPI at treating esophageal eosinophilia. And while there was a time where PPI-responsive eosinophilia, or PPI-RE, was thought to be a unique entity that needed to be ruled out in the diagnostic algorithm for EOE, that's no longer the case, and we simply think of PPIs as being a first-line treatment for EOE. What you're seeing here is a summary of many studies looking at the efficacy of PPI at inducing histologic response. Despite the heterogeneity in trial design, histologic response definition, and specific PPI dose, frequency, and duration, you can still see that the overall average response for PPIs was about 50%. Now, when it comes to the mechanism of PPI efficacy, initially it was thought that PPIs were treating comorbid GERD. And the idea was that exposure of the esophagus to gastric acid led to loss of mucosal integrity, which then allowed for food antigens to activate the immune cascade leading to EOE. Over time, however, it became clear that there had to be an anti-inflammatory mechanism to explain findings in animal models, as well as in people who had response to PPIs but normal acid exposure on testing. We now know that PPIs can inhibit migration of inflammatory cells to the esophageal epithelium through multiple mechanisms, including interference with the eotaxin 3 mediated recruitment of eosinophils. While we know that PPIs can be safe and an effective first-line treatment for EOE, patients are often very concerned about the adverse effect of PPIs, which you've heard about in the last two talks, so I'm not going to talk about it more here, except to say that there are a few things you can counsel patients about, but overall, the risk-benefit profile for PPIs, especially in EOE, is quite favorable. Bottom line, PPIs are a first-line treatment for EOE with a 50% histologic response rate. That said, data around which PPI, at what dose, at what frequency, for how long, for what patient is not known. And the holy grail of precision medicine, looking at clinical phenotype, epigenetics, transcriptomic, genomic, proteomic, metabolomic markers to be able to predict which patients will respond to PPIs or any medicine for that matter, is still a work in progress. So let's move on to another first-line but also off-label treatment for EOE, which is topical steroids. So there have been 8 double-blind placebo-controlled randomized control trials that show about a 65% histologic remission in patients treated with corticosteroids. There are 2 common formulations currently in use. The first is swallowing fluticasone delivered from an inhaler, and the second is creating a slurry from budesonide respules formulated for use in nebulizers. In terms of which steroid to choose, this is data from a randomized control trial comparing budesonide slurries to fluticasone inhalers. And as you can see, there was no significant difference in histologic response, dysphagia symptom questionnaire score, or ERUS. In my practice, what this often means is making a choice based on insurance coverage as well as logistics of swallowing a medication formulated for inhalation versus compounding a budesonide slurry at home with Splenda or applesauce. In terms of side effects, candida infections are the most commonly reported at 10%. While there has been concern for adrenal suppression, the thought at this point is that the risk of clinically significant adrenal insufficiency, even with higher doses and extended therapy, is likely to be small. And it's worth noting that there's extensive literature looking at comparable inhaled steroids used for treatment of asthma in adults and children, showing an excellent safety profile. One final note is about novel steroid formulations. So while there were high hopes that a budesonide oral suspension would become the first FDA-approved medication to treat EoE, it was unexpectedly rejected by the FDA in December of 2021. There's a related orodispersible effervescent budesonide tablet that's approved in Europe and Canada and Australia, and has been for many years, but it's still not approved in the US. There is still some hope, though, as an orally disintegrating fluticasone tablet is undergoing phase 3 trials currently, which hopefully will lead to FDA approval within the next few years. So let's move on to biologics. I'm going to focus on dupilumab, which became the first FDA-approved treatment for EoE last year. That said, this chart gives you a good sense of how our improved understanding of the pathogenesis of EoE and the identification of key factors in the immune response has led to the development of many immune-targeted and monoclonal antibody treatments. You'll notice that the majority of the ones I'm showing here are targeting the IL-4, 5, and 13 pathways, but there are a lot of other immune targets out there as well. So let's talk about dupilumab. So this is a monoclonal antibody that targets the alpha subunit of the IL-4 receptor. This subunit is part of the type 1 and type 2 IL-4 receptors, as well as the IL-13 receptor, meaning that it inhibits the IL-4 and 13 signaling pathways, which are key drivers of the Th2-mediated inflammation that we talked about earlier. For EoE specifically, the pivotal phase 3 trial results were published in the New England Journal at the end of last year. This was a 3-part randomized control trial, and in Part A, patients received 300 milligrams via weekly injections or placebo for 24 weeks. In Part B, they received 300 milligrams of dupilumab weekly or placebo or dupilumab every 2 weeks. And in Part C, 77 patients from Part A received 300 milligrams of dupilumab weekly for 28 more weeks for a total of 52 weeks. The primary endpoints were histologic remission and change in dysphagia symptom questionnaire at week 24. And what you can see here is that histologic remission in the dupilumab groups was significantly more than placebo at about 60% response, and that response persisted at week 52. In the lower image, you can see that weekly dupilumab resulted in reduction in dysphagia symptom questionnaire score. However, the Q2 week dosing failed to show a difference over placebo. In terms of adverse events, the overall incidence was similar in both dupilumab and placebo groups, and only one of the 10 serious adverse events, which was the development of SIRS, was attributed to dupilumab itself. That said, the most common reactions across all the data of dupilumab, including that in the allergy literature for other conditions, are injection site reactions, URIs, arthralgias, herpes viral infections, parasitic infections, and conjunctivitis, and all of those are worth mentioning to your patients. Before we move on from Dupixent, I want to share one case report published at the end of last year showing a dramatic resolution of stricturing EoE while on Dupixent. This was a case of a 14-year-old boy with fibrostenotic EoE whose initial esophageal diameter was 5.4 millimeters, and you can see that in the image on the upper right that shows that the diameter was less than the size of an open biopsy forceps. Over the course of a year, he was treated with PPIs, systemic steroids, topical steroids, dietary eliminations, and multiple dilations without lasting resolution of his narrow caliber esophagus. He was then started on weekly dupilumab, and within a matter of months, you can see the results in the bottom image, in which the diameter of the esophagus has improved dramatically. You can actually see the LES all the way from the mid-esophagus, and no further dilations were required. Of course, this is just one case report, and more robust studies will be required, but certainly having a medical therapy that improves both inflammatory and fibrostenotic EoE features would be welcome, given that the only other treatment we have for fibrostenotic disease is dilation. So fortunately, dilation can be quite effective and safe, despite the scary tears that can sometimes occur. So here's data from a retrospective cohort study of 509 patients with EoE. Of those, 164 had undergone 486 dilations, and the dilations were very well tolerated with no major bleeds, perforations, or deaths. The overall complication rate was 5%, with 4.3% of that explained by post-procedural pain. So the bottom line here is that, as opposed to prior concerns regarding perforation, dilation in EoE is actually well tolerated with very low risks of severe complications. I'll end the discussion about dilation with a few words of wisdom from Joel Richter that were published in 2017 that still hold true today. Some highlights include that, as we just mentioned, post-dilation pain is common, but it usually responds to reassurance and NSAIDs. In terms of technique, starting low and going slow is always a good idea, and that might mean several dilation sessions every 3 to 4 weeks until reaching a diameter of 16 to 18 millimeters. It's also important to do dilations concurrently with medical therapy to reduce the rate of restricturing. One final treatment to consider is creating a care team. I find that working with dietitians and allergists is really invaluable in the treatment of EOE. Of course, dietitians are the true masters of elimination diet tips and tricks, and allergists can help manage comorbid food and environmental allergies, which are quite common, not to mention that they have a lot more experience using biologics like dupilumab and others than we do in GI so far. So to summarize, here's the AGA clinical practice guideline for EOE management that was published in 2020. You can see that dietary therapy and medical therapy with either PPIs or topical steroids are all first-line choices. For patients with stricturing disease, you can see that that is a needed component in management as well. Since this was published before Dupixent and FDA approval, I've added Dupixent to the algorithm, though I'll note that when to use Dupixent is not yet established officially. In my mind, I think of it as a second-line treatment when other first-line treatments have failed or if patients have significant fibrostenotic disease. With that, I'll thank you for your time, and I'm happy to take questions at the end of the section.
I'm going to be the next person who talks, and I'm going to talk about introductions of EndoFlip and all the excitement about the new tool on the block that's been around for a few years. Okay, so we're going to talk about EndoFlip. And so today's talk is going to be, the objectives is to review kind of physiology of impedance, to kind of discuss about how EndoFlip concept actually works. And then I'm going to follow with understanding flip and talking about the protocol of flip itself and how you can use it in clinical practice, especially like achalasia. So as a review, we are talking all about esophagus, and we know that the esophagus is an important organ, specifically because as you guys were eating breakfast today, you needed to get the food from your mouth into your stomach, and that is the function of the esophagus. And the way it works is that we have a lot of muscular motions that contract and relax. We have sphincters that relax and then tense up. So there's a lot of muscular motility that's involved in the esophagus. But to talk about the esophagus, we need to kind of go back to physiology. And the concept is the biomechanical wall properties of the esophagus. Now, there's two components. There's active and passive. Now, active is what you think intuitively, like contractions and relaxations and sphincters. But the passive component is super important as well, and that includes distensibility. Now, distensibility might be a newer concept for people outside of the esophagus world. The idea is that distensibility, by definition, is the radial force of resistance of distension. Okay, so what does that mean? So it's a physics kind of terminology, but what it means is how much resistance, how much wall tension are you experiencing when something stretches open? Specifically, if you're looking at the lower esophageal sphincter. If I need food to go down from the esophagus into the stomach, that sphincter, how much resistance is being felt to open up? Now, this is going to be a prelude to why EndoFlip is unique in this way. Because we do have manometry, we have barium esophagram to look at motility, but manometry looks at static pressures in the esophageal wall. It doesn't actually have the capability to look at distensibility in particular. So then I'm going to talk a little bit about electrical impedance, and it's going to make sense a little bit later in a few minutes. Now, the whole reason I'm going to talk about this is you're going to hear the word impedance in a few of esophageal diagnostic tools. So I want you to be familiar with the concept of this term. So what impedance means, it's the change in electrical resistance that is being appreciated through flow as it's going through electrical electrodes. So for example, take the picture up to the top right. So you have a bunch of electrodes right next to each other. And then you're going to have a flow of something going by. Impedance is measuring the resistance that is being felt as it's going through and flowing. So for example, and this really depends on the ionic concentration of what is flowing from, say, left to right. So for example, say acid reflux. acid has a lot of ionic concentration to it. So there's less resistance that is being appreciated as it's flowing through the electrodes. But take that in contrast with gas, like air that we have right now. There's very little ions in air, so there's higher resistance that's being appreciated. And this is how we measure impedance. Now, I'm going to tie this all together very shortly, but FLIP, which is the topic of today, is an acronym for Functional Lumen Imaging Probe, and this is a cartoon picture on the right-hand side of what EndoFLIP looks like. Now, EndoFLIP focuses on measuring mechanical properties of the esophagus. Aha! Because we know manometry doesn't actually have that capability quite to that detail. It utilizes impedance planimetry during volume-controlled distension to measure cross-sectional area. And then at the bottom of the catheter, you have a single pressure transducer that can measure pressure in the fluid-filled bag. Now, there are some techs and some nurses in this room, and some of them may ask you, hey doc, do you want a 325 or a 322N catheter? And you're like, what does that mean? Well, there's two different types of measuring catheters that we have for EndoFLIP, and it really depends on the size of the balloon. So on the left-hand side is your 322N 16 centimeter balloon catheter. If you look at the picture, you see that the balloon, when it's inflated, a lot of it is in the esophageal body as well as hugging around the EGJ. So this is a very long balloon in the esophagus. In contrast, the 325N catheter balloon is 8 centimeter balloon. So you see on the right-hand side, very, very short balloon. All it's doing is measuring numbers in the EGJ, but doesn't have a lot of information of the esophageal body itself. Now, the technical aspects of EndoFLIP, it's a 240 millimeter length catheter. It contains, It contains 16 paired impedance planimetry electrodes, which we talked about why impedance or what impedance is. The impedance electrodes are located in a balloon that has conductive fluid. So it has to have some level of conductive fluid to be able to measure the electrical resistance. Now, the important thing is that the balloon itself is infinitely compliant. That's important to recognize that this balloon is not meant to stretch or dilate. It's very, very soft of a balloon. All it's doing is measuring numbers in the esophagus, but not meant to dilate. Now, for people who are outside of the physics world, this took me a little bit of time to grasp, and I'm going to give you just kind of the overall concept of this. If you take impedance information, you can get information on voltage. And if you leverage Ohm's law, voltage can give you information of cross-sectional area, which is the picture on the top right, just to remind everyone what is cross-sectional area. Why that's important is that from cross-sectional area, you can estimate diameter of the lumen by using this equation. So you can actually get a sense of how the diameter is in the esophageal body, in the lower esophageal sphincter GEJ direction. But you can also measure distensibility. And how do you do that? I'm going to give you the equation from below. Distensibility equals the median cross-sectional area over the median interbag pressure. Okay, so hold on. So remember, we had impedance that gave you information on voltage, that gave you to leverage Ohm's law. Now I have cross-sectional area. Okay, so now I have the numerator of this equation. And then remember, in the balloon cartoon picture from before, there's actually a solid state transducer to measure pressure when I inflate the bag. So I have all the answers to the equation of measuring distensibility. So it's quite cool of what EndoFLIP can add to information on the biomechanical properties of the esophagus. Okay, so moving on to methods of how we use EndoFlip. So it's a catheter that you position. You do it endoscopically while patients are sedated. That's the US way that we do it. And then you position it along the GEJ because you're really trying to get informations of distensibility of the GEJ and the lower esophageal sphincter. It's volume controlled distension, so you distend the volume. And there's a level where you really need an adequate pressure that the balloon is kind of distending to get a good pressure to get accurate measurements. So many of us will start measuring at 30. I start actually measuring at 40, but nonetheless, you're trying to distend the balloon at 10 cc's in increments of time. And it's stepwise. Now, where do you stop distending and where do you kind of say, okay, I'm done? In the 325 or 8 centimeter balloon, because it's a short balloon, we stop at 40 cc's. Now, most of us in the room who do EndoFlip here like to go towards the 16 centimeter balloon. Why not? You get more information. So in that situation, we usually stop at 60. I think most of us stop at 70 cc's, which is the maximum of the balloon fill. Now, this is what EndoFlip looks like. So if you're going to do EndoFlip in the endoscopic unit, in the operating room, this is what it's going to look like. So you're going to have the volume of how much fluid you're putting in and how much you have left. You're going to have a little waste. So remember, I'm putting the balloon around within the GEJ. So the GEJ has a lot of muscle there. So I'm going to get a little waste. And that's actually how you're going to figure out where my balloon is being positioned. I'm going to get information on pressure because I need that for distensibility. I'm going to get on the top the diameter, so I can estimate the diameter not only at the GEJ, but I can get a sense of the esophageal body as well. And then I can get a calculation of my distensibility. So this is what EndoFlip will look like. Now, there are some differences between EndoFlip 1 and 2 because I have a 5-minute marker. I'm going to skip over this. But what I'm going to talk about is EndoFlip 2.0. And the way this is cool is you have to use a 16 centimeter balloon. And because that balloon is in the esophageal body, I can actually get information on secondary peristalsis. So you guys all ate breakfast today. So when you were eating the bagel and the cream cheese, you had primary peristalsis to get the food down. But secondary peristalsis is what triggers after the balloon distends. That's secondary peristalsis, and that is what I can measure on EndoFlip. You can have repetitive antegrade contractions, which means that things are going in the forward motion, which is right here. So things are going in the forward motion. You can get repetitive retrograde contractions, which is going in the opposite directions. And then you can get absent, which is down to the left, which is nothing. Now, it can get even more complex. I'm going to skip over this slide just because I think this is just a little too complex for today. But I just want to make the point that it can get even more complex on how you're looking at EndoFlip numbers. But how can FLIP be applied clinically? This is really the most important part of the talk. Achalasia. So remember, achalasia physiology means that the lower esophageal sphincter, that GE junction, is not wanting to relax. And that is really what EndoFlip is trying to give you information. Is there a lot of resistance that is being felt to open up that GEJ? Now, these are comparisons of what a patient in a control subject, what their distensibility numbers would be like, and in comparison to untreated patients with achalasia. So for you and I in the room who don't have dysphagia or achalasia, our distensibilities are going to be high. At the bottom at 40 cc's, you have 8.2, but you have a confidence interval that's even going to 18. If you compare to patients with untreated achalasia, you see that their distensibilities are very low, 0.7, with a very, very short confidence interval. So patients who have a distensibility number less than 2.8 or below, that is concerning for something is going on in the GEJ. So if you're doing EndoFlip and you have a distensibility less than 3, you got to really ask yourself, there's something that's going on there and I need to investigate further. And to make it simple, the way that you can use topography is by comparing patients who have achalasia with what can be seen on topography. So normally we should see repetitive antegrade contractions. In achalasia type 1, because there's absent peristalsis, you're going to see absent secondary peristalsis. In achalasia type 2, it's variable, whereas achalasia type 3, you're going to see repetitive retrograde that's more associated with spastic physiology. So, unlike manometry, where we have the Chicago classification, we have a great consensus statement on how to use it, what to do. EndoFlip, to this point, I don't believe we have. So we just have a few really good sites that are doing a lot of research in this area. But we do have the best practice advice, and I highlighted things that I think is important. And I think that really the take-home thing is EndoFlip is a great diagnostic tool, allows you to get a lot of information. But at this very point, it's not the sole way that we diagnose, and I think it's recommended to use it as complementary. So you can get barium esophagram, manometry, EGD. In addition, you can use FLIP to kind of aid in that diagnosis. And with that, I'm going to say thank you, and we're going to move on. And I'm going to introduce Dr. John Clarke, who is one of the co-directors for the CME course. He's also a clinical professor and director of our esophageal program since coming here from Hopkins in 2016. His focus is all things esophagus, including motility, amyloid, scleroderma. He knows it all. He has over 100 publications in PubMed, so he's quite the expert in esophageal diseases. And with that, Dr. Clarke, you have the podium.
Okay, well, thanks very much. And I'm going to try and whirl through this diagnosis within 15 minutes. So what I'm going to try and do is to talk about a little bit of how patients present, as well as what the mechanisms are, and then talk about diagnosis and therapy. And if we look at the term itself, it's really derived from the Greek words, which mean absence of relaxation. When we look at achalasia, we know that mechanistically it's defined by loss of inhibitory neurons leading to absent or else aberrant contractions within the esophagus, plus a tonic contraction of the lower esophageal sphincter. It's reported to be 1 in 100,000, though, as I'll talk about a little bit more, that seems to be increasing. And it really can occur at any age, though it's more frequent as people get older. If we look at this historically, Sir Thomas Willis, who is famous for several things besides this, was the first person to really describe it. And he had a patient back in the late 1600s that he treated with a whalebone, which he put a sponge on top of. And then after meals, this patient would place this bone down and kind of pass it throughout their esophagus. And they did that for approximately 15 years before dying of something else. And that's why if you look at the type of dilators we have now with savory dilators, they're based on this same form, based upon this past way of doing it. Therapy has been relatively similar for about the last 130 years at this point, and it's really been designed to disrupt the junction. So we don't have a way to really restore the peristalsis, but our main therapy is based upon disrupting the muscles to let things pass through more. And so we've had large caliber dilations since the late 19th century. The first Heller was actually performed in 1913. The first use of Botox was in 1993, and the first poem was first conceptualized in 2007. If we look at how these patients present, dysphagia to solids and liquids is the classic way, but it's important to note that although we think of solids and liquids, not everyone presents with both, and so you will have patients who may present with just solids without liquids, particularly in the first couple years. It's also worthwhile to note that heartburn is often reported in about 40% of people. And the thought is that it's not reflux per se, but it's more stasis of contents within the esophagus which ferment. From a brief mechanistic standpoint, what we're looking at is how do we get from this healthy esophagus on the left there to this kind of diseased esophagus on the right. And given that I've got 15 minutes, I'm going to kind of blitz through this a little bit. But it used to be thought until about 30 years ago that the neurons just kind of, would disappear with time and age. And it's now recognized that what probably takes place is that there's some inflammatory reaction. And then in people who are susceptible to have some sort of cross reaction, they'll end up developing an immune reaction which knocks out the neurons in that area. And so the thought is something inflammatory, which is typically infectious, triggers an immune response, and this is what leads towards this. Now, it's interesting to note that parrots have this particular type of infection that's a virus that will cause something that looks like achalasia. And so this is actually the second leading cause in a parrot death in the world, and is apparently a crisis to those that study tropical birds. But it's never been found in people. So possibly in 10 years we'll have a very different talk when we found this parrot corollary. But for right now, the thought is something infectious triggers this immune response. So this is typically reported as 1 in 100,000, but there's been at least 2 papers within the last decade that have shown that it's probably about 3 or 4 times more common within the last few years. And if you look at most sites across the U.S. that work in this, everyone behind the scenes will say that they're seeing a lot more of this. And so I see at least 1 new case a week in my clinic, and it's sometimes a little tough to tell in that we have a tertiary bias, so we do get patients from a ways out, but it still seems like a lot for something that's this rare. And the thought is that maybe with the increased change that we're seeing with different immune disorders in general across the board, that might be also increasing this as well. There's also a number of case reports suggesting that with COVID, it's possible to get this afterwards based upon inflammatory change. Now, if looking at the diagnosis, because these patients are really presenting with swallowing issues, your first and second steps are typically endoscopy and barium. And it's important to note that you will occasionally see these types of tests where you have the classic bird beak appearance, dilation, food present within the esophagus. But this is a relative rare case, and you'll see this in approximately 1/4 to 1/3. And this is typically in those patients who are end stage or who have had symptoms for quite some time. More often, the endoscopy and barium study are relatively normal or have findings which are subtle. And so typically with endoscopy, what you might see are more frothy secretions because they aren't being cleared. You might see a contracted sphincter that takes a little bit of resistance to pass, but it's not uncommon that the endoscopy itself looks pretty normal. In terms of barium study, if you do a time protocol where you're basically drinking barium, then you go back and take a picture at 1, 2, and 5 minutes, you might see some retention of barium, but if you're looking just in split seconds in passage, oftentimes it looks pretty normal. So what do you do in that situation if you have a suspicion with achalasia, but the endoscopy and the barium study don't define it? And we've got 4 options here, and I'm not going to talk about impedance as well as scintigraphy because I think that those are used less often. Flip I'll touch on very briefly, but I want to mention manometry. And this has been in use since the 70s. We've had the high-res system since approximately 2006. And the concept here is that you take this catheter, you numb up the nose, you pass it from the nose towards mouth, and then you ask them to swallow about 10 times. And you're essentially looking to see what's happening with the pressure in the esophagus during this. So what you should see is something like this, where your mouth is at the top of the screen, your stomach is at this part at the bottom, and then when you swallow, you essentially see this upper sphincter relax. You see a slight increase in bolus pressure with swallowing. You see the stripping wave that comes down here, and then you've got the lower sphincter that opens. And if you contrast that with someone with achalasia, you don't have to be a motility expert to see that this is very dramatically different. And so what you see here is that the lower sphincter is not opening, everything is really contracted, and you don't have that nice stripping wave, which I showed prior. Now, there's two reasons to get a manometry with patients with achalasia. First one is to make the diagnosis, because this is considered the most sensitive test that we have. But the second is to look and see what subtype it is to get information to guide next steps. So this was first looked at about 15 years back at Northwestern. And what they did was they looked at their experience within a 2-year span, and they subdivided these patients into type 1, type 2, and type 3. Type 1 is what we think of as those patients with more of a classic presentation. And what you see here is the lower sphincter stays contracted, but you don't see any pressure in the esophagus as well. And so this is more of a flaccid esophagus that doesn't generate anything. Type 2 is where, once again, the lower sphincter looks exactly the same. Nothing is opening, but you get this pressurization throughout the esophagus. And the thought is, at least, that what's happening is that you've still got some tension from the outside muscles in the esophagus. And when you increase the contents and diameter, you then generate this contractile force. And then type 3, once again, the lower sphincter looks exactly the same, but you've got this spasm above it. And so if you then take these subtypes and look at the outcomes, you can see that those patients with type 2 really respond to anything you do. So whether it's dilation or Botox or else Heller, these patients generally do pretty well because they generally still have outside pressure to generate a force. Type 1 patients, because they don't generate anything, you really need to disrupt the sphincter more aggressively. And so this is a group that does better with Heller myotomy, for instance. And then type 3, where it's more spasm, just going after the sphincter alone may not be enough. And so this is a group that Botox or POEM now works better in. Now, FLIP, I won't talk about as much because we've just had a great talk on that, but I want to just show how this can be useful in practice. And so this is a patient that I saw a few years back, 30. He'd had a very good local workup, 3 endoscopies, stretched twice without improvement, barium esophagram showed spasm, 2 separate manometries, and there was suspicion he may have a variant of achalasia, but it wasn't proven. And so we saw him and did FLIP, and what you're seeing is that this catheter is across the sphincter, and the lower and right here is 20 cc's of fluid, and you can see you get to a diameter of 5.5 and a pressure of relatively low. Same site, it goes from 20 to 50. And you can see, diameter doesn't change, but the balloon pressure really shoots up. And so based on this, it was possible to say that this is, that this patient does have this patient ended up going towards POEM and did very, very well. So in the last couple of minutes, let me look towards how we treat this now. So if you make a diagnosis of achalasia, because we think that lack of therapy will lead to continuous dysfunction within the esophagus, and about 5% of these patients eventually require esophagectomy, we like to treat once we've, once we're confident of the diagnosis. Typically medical therapy has a role mainly as a bridge therapy towards doing something else, but there's not good evidence that it'll change anything in terms of the natural course of this. And so you're left with the other options that I have here. Botox was first developed about 30 years ago, roughly. And the very brief with this is that it works in about 70% of people. It's very safe. It works for about 9 months, but it typically recurs afterwards. And if you do it again and again, you've scarring within the area, and it becomes less effective with time. And so the current thought is that if you're not sure of the diagnosis, if you think the patient is too frail to do something more aggressive, or if you think they have a life expectancy of less than 2 years, then this becomes a good option. If not, probably best to think of something else. In terms of dilation, this has been in use since the 19th century, and the goal is that you stretch with a balloon of anywhere from 3 to 4 cEMs in size, trying to tear things in terms of the sphincter, but not tear it the whole way through, which can be a somewhat delicate balance. And if you look at how well this works, it works in about 3/4 of people, but it works better the more aggressive you are. So if you start at 3 centimeters, about 3/4 of the time it gets better. If you're willing to go to 4, you can get 90% improvement, but you're going to bump up the rate of possible perforation from 1% to about 4%. And most of these patients who do get better will require something else with time, though it's typically just stretching again. This was a very, very, very seminal paper that came out now about a decade ago that looked at a pneumatic versus Heller. And what they found is that if you're aggressive enough in terms of balloon, you can do as well as a Heller myotomy. But the caveat to this paper was they had a rate of perforation of 4.1%. And that's actually somewhat misleading because they did have perforations in 4 of their first 12, and then they said, wait, let's just start over. So it actually was somewhat higher. Heller myotomy, tried and true. It's been out since 1913. The first case laparoscopically was 31 years back. Mean rates of success are typically quoted about 90% at 3 years. And the big selling point of this, besides the long-term history, is GERD. So if you combine this with a partial wrap, your rates of GERD are thought to be about 10% or less. And that contrasts with doing balloon, that's about 20%, and POEM, which might be as high as 40. And then to end, POEM was first conceptualized in 2007. The first case in people was 2010. And it has a certain elegance with the idea that we think that most of the dysfunction with this disorder is really starting from the inside and going out, and POEM lets you go and cut the muscle from that course. Fast recovery, there's no scars, patients do great. It's a fun it's fun to do as well. So it's led to a lot of enthusiasm in terms of doing this. I've been told by some people, joking, but perhaps not quite, that achalasia is cured within Japan because everyone has had POEM. But there's been about 8,000 worldwide. The two questions with this are, one, we don't have the long-term follow-up yet. So so far the most we have is 5 years out. And then second, the rates of GERD are probably higher, though that's an area of controversy. So to end, this is increasing in incidence, but still rare. If you're not sure of the diagnosis and you have suspicion, get a manometry. The subtype predicts what patients do best with. FLIP is now up and coming, and it wouldn't surprise me if in 5 years we're doing FLIP first, but we're not quite there yet. Think of Botox if you're not sure of the diagnosis or risk is very high. Once you get beyond that point, dilation, POEM, Heller really becomes dealer's choice. And so it's based on patient preference and local expertise. And that POEM is rapidly becoming the standard of care in those centers that do it. But there's still questions about the long-term effects, plus also GERD. Thank you.
All right, wonderful. I have the pleasure to introduce our last speaker, who's Dr. Mary Hawn, who's going to talk about how she approaches dysphagia in the setting of a prior fundoplication. We're delighted to have Dr. Hawn with us today, coming from the Department of Surgery. She's actually both professor and chair of Department of Surgery here at Stanford. I also recently learned she's a director of the American Board of Surgery, as I was looking her up as well. She has a clinical focus in minimal invasive foregut surgery and is intimately connected with our esophageal group as we discuss a lot of management of complex foregut pathology. Dr. Hawn, you have the podium.
Great. Thank you so much. Okay. All right. Well, it's a pleasure to be here this morning, and really even a greater pleasure to have such great colleagues in gastroenterology and esophagology to take care of these complex patients. I have no disclosures. So the goals, I just want to talk a little bit about evaluation of the failed fundoplication and then surgical and non-surgical interventions. So surgical correction of reflux, I think we all know it's getting the right patient to surgery and then performing the right operation. And this is where we really work closely together in identifying those patients and working them up and making sure that we're thoughtful about what is the best operation for them. And that, I think is the best way to mitigate post-fundoplication syndromes. So this is probably a graph you have seen or are very familiar with, and this is getting the right patient and working up what is that diagnosis of a patient who comes in complaining of heartburn, chest pain, reflux. As we know, it's not always pathologic acid reflux. So going through these pathways of erosive esophagitis, non-erosive esophagitis, functional heartburn, et cetera, and identifying the treatment algorithms for them and then getting the right patients referrals to surgery. So what is the incidence of revisional fundoplication surgery? If you were in my clinic, you would think it's about 50%. It seems about half of the patients that I see are being evaluated had some prior fundoplication and now come in with a complaint or a new symptom. And so, but in a large cohort study, mean follow-up of 8 years, about 4.6% of patients will undergo some revisional fundoplication surgery. And most of those are going to happen early. So usually if somebody does well for the first couple of years, they usually do well long-term. So it's those kind of early failures, early recurrences that are the patients that we see, and whether that was an inappropriate operation or not an appropriate patient for surgery is what we need to figure out. So what do we do when we see somebody who's having recurrent or persistent symptoms following a fundoplication? First, we want to start from the beginning. We want to look at their records. What workup did they have before they went to surgery? What were their symptoms that they had before they had their initial surgery? And how do they compare to their symptoms now? So were they extraesophageal symptoms such as cough, et cetera, or were they classic symptoms of heartburn, regurgitation? We want to see, did they have manometry, pH studies? What was their symptom index? Were they well selected for surgery? Did they have a big hiatal hernia? We know that large, especially paraesophageal hernias, are associated with higher rates of failure recurrence. And and then we also want to look at the operative report and make sure what they found at surgery and was there anything technical about the repair. So these are the types of symptoms that we all see together, patients who've had a fundoplication. Some come in with recurrent reflux that may or may not be controlled with a medical therapy. They may have had weight gain that may predispose to an early failure, return of reflux symptoms. And so it's important we want to know what's the severity of this compared to their pre-operative symptoms. Dysphagia is a common one, solids and liquids. When it occurs, how it occurs is important. Have they had weight loss? Is it constant? Is it just happening a couple times a month? And did they have a pre-op manometry study performed? Bloating is, I think, the Achilles heel of the fundoplication. So we just ask questions around, are they able to belch? Is it postprandial bloating? Usually we hear it's worse at the end of the day, associated with excessive flatulence. And then chest pain is probably one of the more challenging symptoms to work up. So, I'm going to show a lot of swallow studies. So this is a normal postoperative study of a barium swallow. You see that the wrap is around the esophagus in the intra-abdominal location. The esophagus isn't dilated. Contrast seems to flow through fairly easily. So that's what we're looking for. And so when we see a patient come in, a lot of times we can tell just by history and their symptoms of what we might be looking for and how to work it up. So if it's a tight Nissen, we expect them to have dysphagia but not reflux. They might have bloating for sure. If it's a patulous Nissen, then they probably shouldn't have dysphagia, but they may have reflux. And if it's slippage, slip Nissen, they often have dysphagia and reflux, because if you remember, the fundus has receptive relaxation. So if you have fundus slipped above the fundoplication, you have a relative obstruction against a piece of the GI tract that doesn't have that motility. And so they get dysphagia or food impaction, feeling like food hangs up there. And then the fundus also has parietal cells, so they also have reflux. So this is one, we probably don't see this one too frequently, but just a too tight Nissen or a too tight crura, which can be challenging to figure out. So if you make a Nissen too tight or too long, the patient will likely have dysphagia, but no reflux. And this can be quite bothersome. So it's really important for us to look through the note. How many stitches did they use in the fundoplication? How did they describe constructing it? How did they close the crura? Did they do the wrap around a bougie? All types of things that us surgeons are looking for. Did they put mesh at the hiatus? But with this, usually we'd want to know is if they're really complaining of dysphagia, did they have normal preoperative motility? So did they have a study done prior to surgery and has it changed? So we're going to repeat a manometry. How bothersome is it? Is it just a common symptom of fundoplication patients is that they say they feel like their food gets stuck if they eat their first and second bite too quickly. And that makes sense to me because, again, that fundus has receptive relaxation as we eat. And so then they'll say if they wait 5 minutes, they can sit down and just eat normally. So we coach patients on how to eat, like, if they're having a lot of these symptoms, try just, taking a bite of a cracker, a sip of water, wait a couple minutes, sit down, then eat your meal and see if that helps. And we try and give them those types of tips early on after surgery too, as they're advancing their diet. So are they having a lot of bloating? Could they have achalasia? Were they misdiagnosed? As Dr. Clarke just said, sometimes achalasia can be, they come in, reflux is very common, achalasia is not. They have a normal endoscopy. Somebody makes an assumption, well, they must have reflux, send them off to their favorite surgeon for surgery, and lo and behold, they don't get better. So what we do is, repeat the manometry, pH, and then usually I would start with a dilation. Is this something we can treat? Is it kind of scar tissue around the hiatal hernia repair, crural repair? Is it the crura is just a little bit too tight around the esophagus? Can we disrupt that a little bit with a dilation? So we would kind of start with that before we would go on to revisional surgery. So this is another type of fundoplication failure that we see, kind of the disrupted or the dehiscence. So it's in the right location. It's not herniated. It's just not providing enough, augmentation of the sphincter. So these things, the main thing that we work on a lot is patients who are obese, especially morbidly obese. And reflux is a very common symptom. And if they aren't able, our first treatment for them would be weight loss. And whether it's medical weight loss, if they lose weight, sometimes the reflux symptoms get better. But we wouldn't go to surgery, hiatal hernia repair, and a patient who's with a BMI over 35. We would, if their reflux was very symptomatic, they weren't able to lose weight, we would send them over for evaluation consideration of a Roux-en-Y gastric bypass as the first potential treatment for their reflux. So that's, and so if somebody comes in with a dehisc wrap, did they gain 30 pounds? Is there some reason that may be contributing to their fundoplication failure? So again, we work them all up again, and in these patients, if all those other things are negative, this is some patient who would probably do pretty well with the revision of their fundoplication. This is probably the most common one that I see, the slit fundoplication, where you can see here the wrap is in the abdomen, but the stomach has slipped up through the wrap. And these patients are, I think, the most symptomatic. They have both dysphagia and reflux, usually does not respond to dilation, and they almost always need to be revised. So again, before we do any surgery on them, sometimes they can be managed medically. The dysphagia isn't too bad, but we'll work them up and make sure we understand their underlying disease. And, if they gain weight, we'll try weight loss, other things that might have contributed to slip fundoplication. We see it in patients who typically have big hiatal hernias. And Dr. Kamal did scrub in on some surgeries with us, so she's seen some of these big hiatal hernias. And there's a big fatty hernia sac around the around the hiatus. And so when we're constructing the fundoplication, it's always not the most gratifying because you're not looking at nice, muscular esophageal wall. Always there's a lot of hernia sac there. And so you're kind of trying to debride that off, but there's the vagus nerves too. So it's kind of a balancing act. So anyway, so these are patients we just want to understand, did they have something? Did somebody operate on a very obese patient? Should they maybe even just go on to a Roux-en-Y instead of a revision of this? Right, and this is one that is incredibly symptomatic and almost always needs to be operated on. This is a circumstance where they use the wrong part of the fundus or the wrong part of the stomach to do a fundoplication, and it was often done with the body, and you get this compartmentalization of the stomach. Again, we talked about how the fundus has no motor activity, so it basically compartmentalizes the stomach, and they need to be revised. Fortunately, this doesn't happen too commonly. But again, we'll just work them up the same way. This is one kind of a herniated fundoplication. This is thought to actually be not a bad anatomic outcome. If you have the fundoplication around the esophagus, even if you have transthoracic migration of that, most patients will be asymptomatic from this. They usually don't have dysphagia unless the crura are tight and they're kind of obstructed at the crura. And if the fundoplication is intact and in the right location, it will often prevent reflux. So again, this is a patient that probably might be really hard to get a more optimal anatomic outcome from. That may be a shortened esophagus. In a revisional surgery, it's not any easier to get the GE junction back down into the abdominal cavity. So these are people I would probably be less enthusiastic on doing a revision on unless there are extenuating circumstances. So, and then this is, I think, the bane of all of our existence. I think you probably have a whole session on gastroparesis, but this is, I think, another thing that we worry about. We're actually hopefully going to be doing a clinical trial pretty soon that will allow us to help visualize vagus nerves during foregut surgery. Sometimes, especially with big, huge hiatal hernias, the anatomy is so distorted, the sac is so distorted, you don't always see the nerves. And so I'm hoping that that as we advance surgical and endoscopic techniques, that we'll have some of this visualization to help us better identify structures and abnormal anatomy. But gastroparesis, obviously, very bothersome to the patients. Working really closely with our GI, colleagues about trying to figure out, is this a vagus nerve, a pylorus problem? Is it something that can be anatomically treated? Is it functional? And what are the treatment options for these patients? And gas bloat, the bane of our existence. This is a lot of behavioral modification, maybe dilating the wrap if it feels like the wrap is too tight, to see if we can revising them to a partial fundoplication. So overall, revisional surgery does result in pretty good long-term follow-up compared to primary surgery in the right selected patient populations, both in terms of recurrence of reflux, a hernia, and/or dysphagia. So it is worthwhile. It isn't, insanity doing the same thing over again and expecting a different outcome is not always true. And I think we can help a lot of patients with revisional surgery who are very symptomatic. So I think that really what we benefit from here is just a very strong multidisciplinary approach to these patients, both initial complicated patients we're seeing initially for surgery, as well as revisional surgery. And I'm sure we have a weekly conference where we put on these complicated patients and try to get to the best order of management of them, as well as to help get them the best outcome. So thank you very much for your attention, and I look forward to the panel discussion.
What a great way to start the morning, all the esophagus talks. I just want to say a round of applause to all our speakers today. I think we're going to now start the panel discussion. I think we should have people, okay, we'll have the speakers come to the front. So question number one for Patty. What kind of monitoring is needed for Dupixent? And how often do you repeat endoscopies on that therapy?
So it's still pretty new. This was just FDA approved this last year. So in some ways, we're figuring it out. Prior to that point, it was just with the clinical trials. There's a bit of a debate in the field. So on one hand, there's one expert within Europe who recommends everyone with EOE get surveillance endoscopy once a year. On the other hand, there's one expert in Florida who makes the case that if you're not adjusting therapy and they're doing well, that you should never look again. So in practice, we end up discussing this with the patient and kind of doing a case by case basis in terms of when to look. If starting it because they're symptomatic and they have a cell count that's high, typically we'll look about 12 weeks afterwards and just see if there's any response. But if they do have a complete response and they're doing well in terms of symptoms, there's not necessarily a guideline in terms of when to look again afterwards.
Now, a follow-up question, Dr. Clarke, for that is, what happens if they don't respond? So say we do Dupixent as a second line, you do the biopsies, the eosinophils are greater than 15. What do you do in that type of situation?
No, it's I think the challenge with EOE is that it really becomes a composite of diet plus dupilumab plus topical steroids plus also the PPIs, and you're in practice the studies are mostly one therapy versus another, but in actuality in the real world you're often doing a little bit of this and a little bit of that. And so I think if you've done just dupilumab and they're still symptomatic, then you're looking to add on one of these other therapies and reassess. The question is, what do you do with dupilumab in that situation? Because it's quite expensive to do, and it's a hassle in terms of doing the injection. So I think that becomes a question whether they've had a partial response or not. I mean, if their counts are down from 200 to 30, but they're not zero, then you'd keep that and add on something. If their counts are unchanged, you'd probably stop it.
Great. Next question, this is going to be for Dr. Shah and Dr. Jiang kind of together. Is there any reason to believe, recognizing the safety profile of PPIs, we had a long discussion of this. Now we're going to go to PCABs. What do we think that the safety profile would be like for PCABs? Do we think it's going to be similar to PPIs? Will it be different? How do we talk to our patients about this?
I think only the time can tell, because we don't know much about this PCAB. It's kind of a new kid on the block, so we don't know. Once we start using it, the same thing happened with omeprazole, which got approved in '89. We never started talking about it till 2006. So I hope that we don't run into the safety profile with this, but we don't have an answer right now. It is very effective acid blocking agent. Just to give an example, 10 milligram of vonoprazan is equivalent to 60 milligram of omeprazole. That is that effective.
Yeah, I think there's no real reason to believe that the profile will be necessarily different. I think some of these studies did look at the histologic changes with the stomach associated with like the elevated gastrin levels that come with it, but there was really no clinical significance or detriment that they could see in the limited follow-up studies that they had with that. So beyond that, there's really probably no reason currently to think that it would be a lot different than the PPIs, but again, time will tell.
Wonderful, thank you. All right, I have a question for Dr. Hawn. This is going to be a question coming from me, but I think it's always nice because you are a surgeon in the room. So I have a patient who comes in with reflux disease, and I think that they're a good candidate for surgery. What preoperative tests do you like?
Do I only get one?
No, you get as many as you would like. What do you recommend to the crowd?
So I think they should have a pH study that, with the symptom index, associated probability. I like a manometry, and then I get a swallow study on everybody, because if the manometry motility is not done by our experts, that I'm not always sure in terms of how accurate it is if we don't get the images to read it. So, and the motility, and okay, I see people with their entire stomach up in their chest, right? So I get, the patients come in and say, my GI doc said I have a huge hiatal hernia. and it's just a little sliding type 1 hiatal hernia. So the picture is worth 1,000 words. So I love the barium studies. It gives me some insight into function and the size of the hernia as well. So I like all three. And endoscopy as well. So
Sure.
I get 4.
What about a gastric emptying study? How do you feel about a gastric emptying study?
So I don't get a pre-op study on everybody, but if they come in with a lot of primarily bloating symptoms, if medical comorbidities, if something's seen on endoscopy, retained food, any index of suspicion, I have a low threshold to get one, but I don't get it systematically on every kind of pre-op reflux patient.
Wonderful. Thank you. Now, the question for the group is Dupixent. So, when we think of Dupixent, we think of it, I think, maybe a biologic. But there are differences in biologic of what Dr. Kashian is going to prescribe and what we're prescribing. So the question is that can anybody prescribe Dupixent? And is there any monitoring that we have to do? And I think the big question they're trying to sense is, if we're trying to prescribe Remicade, we do some preoperative evaluation, vaccinations. For Dupixent, is there anything that we specifically need to order in advance or vaccinate in advance?
No. So it's it's been FDA approved for treating rhinitis and such for about 6 years now. So while it's new for EOE, it's not new in general. The big thing really is probably conjunctivitis is kind of the big thing people watch out for. But it's unclear that doing a pre-op exam with ophtho, really makes a difference in terms of that, and it's not felt to necessarily increase the risk of infections that much, and so there's really not.
Great.
The only thing I would add is there really isn't much of a difference in some ways to what our IBD colleagues prescribe. In fact, some trials are ongoing and have gone on with vedolizumab and azathioprine looking at it in EOE. So they are all kind of having those mechanisms. But, in the New England Journal trial, the conjunctivitis rate was actually really small. We saw that in more of the allergy literature, so it's worth talking about. But overall, the biggest issue was injection site reaction, and the rest were really small. So I think we talked to patients about it, but the safety profile is really pretty good.
Do you think, and Dr. Kashian, I'm looking at you as well, because they're asking, can I give Dupixent and another biologic together? And I don't know if that's been assessed or not.
I'll defer to John. I think you're probably not going to find much evidence, but you're talking about potentially the patient with some sort of allergic condition, whether it's EOE or rhinitis and IBD. And I think the group here really highlighted Dupixent, which they have much more expertise in, that we don't really expect that there would be a concern there with respect to added infection. So I would imagine that the two diseases could almost be separated. It'd be ideal if we had the same mechanism for both diseases, but I think to me, I don't know, John, you can comment on that. I think that's probably reasonable to think that you can just treat it in isolation without worrying about overlap in any of those things.
I would also just say this is where I think...
Can we get that repeated for the audience online? It's not, we can't hear it.
Oh, God.
Get him a mic? Just summarize.
No problems, that's the answer.
Yeah, no problems is the answer. But what I was going to add too is I think this is where our allergy colleagues can be really helpful. Many allergists actually manage EOE. They also manage a lot of the comorbid conditions for which Dupixent has been used for many years. And so I think if you do have complex patients who are on multiple other immunomodulators or biologics, or you're concerned or you're not familiar, I think it's totally reasonable to involve your allergy colleagues.
Perfect. Okay, I have another question that is coming up. What do you guys do for the group? Somebody is on PPI or reflux management, and they're asking, I don't want my microbiome to be disrupted, and should I take a probiotic or prebiotic? How do you guys respond to that answer? No.
It's pretty much across the board. I do think that if we are looking at any risks associated with the PPIs long term, it's probably in microbiome disruption associated with the pH changes. And problem with with the probiotics is that you're giving back these massive amounts of bacteria, which you don't know if it's normal, and it's not necessarily I think beneficial to bring back 30 billion colony forming units of some type of bacteria that we don't know what it's doing. What I typically recommend is if they're worried about it, and that's it's not most people, but some, then I usually recommend that they take as many fermented foods with it as possible. But I'm not prescribing supplements per se at this point.
I would just add that, we know that acid blocking is a risk for overgrowth syndromes, and there's a lot that we don't yet understand about overgrowth, but certainly sometimes more bacteria, even that's touted as good, is not good for everybody. There's been good data showing that some supplements can lead to excess lactate production, which can contribute to brain fog and bloating. So I just think the science isn't there yet. So I don't recommend it in people on PPIs. If anything, I actually tell them they probably shouldn't be taking probiotics.
Wonderful. Last question I'm going to ask for the group as well is, what if a patient comes into your clinic and is on anti-reflux therapy, some type of medication, and they ask, Doc, do I need specific labs to be checked? Now, Dr. Shah recommended some, but I don't know how routine this is. So in your guys' clinical practice, do you guys check magnesium, a BMP, a vitamin B12? And if you do, how often?
So as I mentioned in my slide, that you check magnesium level in a patient who are on PPI, HIV patients who are on PPI, because 3.16-fold higher risk of hypomagnesemia, definitely with worthwhile checking every year. As the FDA has recommended to check creatinine once a year, and it does result into anemia, iron deficiency, so CBC every 2 years, that's what I do. And then definitely you worry about the blocking the acid too much to cause B12 deficiency, so check it every 3 years. So that's basically what I do in my practice.
Yeah, so mine is a little different. I'd say most people that I see who are being seen in clinic are getting a C, B, C, and a CMP checked probably at least once a year anyway by just their outside doctors. And I think the data with magnesium specifically is relatively quick in the course in terms of a PPI. So if they're going to have issues with it, it's going to be in the first couple weeks in most cases. So I think that B12 is the one that people aren't routinely checking that could be a factor. And although the risk is very low, for patients that I see in clinic who are taking a PPI long term, typically I'll ask them to just get that checked, with their labs with a physical, so not a separate blood draw, but if they're getting labs drawn just because of the annual checkup, I'll ask them to check that too. But that's the only one I tend to add on.
Wonderful. We have one more question for the group, especially also Dr. Hawn, because sometimes people come to a surgical consultation, they want to hear the options, but maybe they're really grasping at straws for maybe something that's non-surgical. And they say, Dr. Hawn and the group, how do you feel about apple cider vinegar?
I don't know. My response on those, if it makes you feel better, I don't think you're hurting anything, but that's with no knowledge. But yes, I do hear apple cider vinegar and baking soda, I think, are the two things that patients will say is what's keeping them alive.
And what about alkaline? I'm going to add to, because this is an actual question. This is not for me. So this is an actual question. What about like the alkaline water? Because this, we live in Silicon Valley, so people are always looking for other options.
Yeah, so I don't think the alkaline water has any real basis. I'll say I have one patient who makes his own at home. He has it all made there, and he's convinced that it works well and helps him. So if people do see a clinical benefit with it, there's certainly no harm with it. But my thought is that everything gets balanced out so quickly that if you take a little bit that's more alkaline, it probably just gets adjusted so fast that it probably doesn't make a difference. I'll say for apple cider vinegar, there's no data, but I feel like I've had so many patients who have said that it's helpful, and there's no harm with it necessarily. So I often say if people want to try it, I don't think there's any downside in doing so. You can at least make the hypothesis at least that the single biggest thing that will break the acid production is a pH that's low. So if you're taking some type of vinegar and it's lowering the pH, maybe that's suppressing the acid, and maybe they're getting better because the apple cider vinegar is less injurious than the acid that they make themselves. So I think at least mechanistically there might be something to go off of, and I've had patients say they like it, but I haven't seen any literature to back it up whatsoever.
All right, awesome. Well, this is a wrap for the esophagus section. We're going to go for a break, and please take a chance to go to the exhibit next door. There's a lot of cool stuff, lots of great things that you can see, and then we'll be back at 10:10. All right, guys, enjoy your break.